Don't Most women shy away from coming to hospital when they are going through issues. So I would advise people to always seek checkup whenever they feel there's something that maybe they are uneasy about something or something seems off with their body. It's good for them to seek checkup. And in case they do that and they don't get an immediate answer, I think a second opinion is always important, because most people shy away from talking about our reproductive system, of which we find it carries such a huge burden. Endometriosis is one of the currently common conditions that affects women's reproductive system, and we've seen quite a number of people currently come out and claim publicly that they are being on the follow-up for the same. This is whereby we have tissue that resembles the endometrium. The endometrium is the inner lining of the uterus. So we find a similar tissue now getting implanted in other parts of the body. We can find this tissue, though it's supposed to be in the uterus, since it's the inner lining of the uterus, but you can find this tissue implanted anywhere else. We can get it in the fallopian tubes, it can be in the ovaries, it can be within our vaginal canal. At times it can even be intra-abdominal, is infertility. So you find people have been suffering, they've been having this painful menstruation, heavy bleeding, they're having issues with their husbands, but maybe years down the line in marriage, when they get getting kids, that's when they end up coming to hospital reporting of infertility. But you find this is an issue that has been ongoing for years. So infertility, I feel at this point now, is always, most of the time, it culminates to that if not treated early.
And does endometriosis have any specific origin or causes?
So there's a lot of debate about that, though currently there is no known cause that you can easily pinpoint. But there have been different theories that have been associated with that. So one, there's the familial history. If there is a first degree relative in your family who suffers from endometriosis, this gives you, as a family member, as a close family member, close to a 50% chance of getting the endometriosis. So it increases your risk factors by close to 50%. The second thing that is thought about is metaplasia, with this, the change of cells. And this is another controversial topic close in the society, since people believe that it's the woman's role to have the family planning level. But we find that family planning by itself, it gives us a chance to plan on when we want to get children and the number of children we want to get, because it helps us to prevent this unintended pregnancy. And so, in a session on all the methods, there are a couple of methods. We find we have different classes of methods. We have the natural method. There are some people who put it, and they mostly use the calendar method, whereby they are able, but for this is for people with regular cycles. So for them, they are able to highlight which are the cases when at regulation, they know those are the ladies with the topic.
Everyone, welcome back to the mashup with Kawira and Maura. This is our 6th episode, and we are happy to have you. And we hope that you're going to stay tuned and get to learn much more that we have in store. Our guest is in our house, Daktari. We would really like to know you and what you do.
So hello, I'm Kendi, Mary Kendi. I'm a clinical officer involved in general clinical practice. Thank you, Kawira, for hosting me today in the mashup. I'm delighted to be a part of this 6th episode today.
You're very welcome. So for today's episode, we will be dealing with different reproductive issues. And maybe to start with, you can tell us why is it important for people to be aware of reproductive issues, especially revolving around women.
So women reproductive issues is something that is currently quite common, and it's quite important because it saves on a lot of time consumed before people go to seek healthcare. Two, it also saves on cost that one uses, because you find most women shy away from coming to hospital when they are going through issues. So I would advise people to always seek checkup whenever they feel there's something that maybe they are uneasy about something, or something seems off with their body. It's good for them to seek checkup. And in case they do that and they don't get an immediate answer, I think a second opinion is always important, because most people shy away from talking about our reproductive system, of which you find it carries such a huge burden from different diseases, different conditions, menstrual conditions such as adenomyosis, endometriosis, we have fibroids. We also have cancers that affect our reproductive system. So I believe if people are confident enough to embrace frequent checkups for this, and also speak up whenever they're having issues, then this could save us a lot of time and finances in terms of healthcare.
Okay. And now that you have mentioned one of the conditions, we would like to delve into, you've called it endometriosis. Yeah. What is that condition all about, and how does it present in the body?
Okay. So endometriosis is one of the currently common conditions that affects women's reproductive system, and we've seen quite a number of people currently come out and claim publicly that they are being on the follow-up for the same. This is whereby we have tissue that resembles the endometrium. The endometrium is the inner lining of the uterus. So we find similar tissue now getting implanted in other parts of the body. We can find this tissue, though it's supposed to be in the uterus, since it's the inner lining of the uterus, but you can find this tissue implanted anywhere else. We can get it in the fallopian tubes, it can be in the ovaries, it can be within our vaginal canal, at times it can even be intra-abdominal, and some patients have even reported such tissue being found in the lungs and also in the brain. So you've asked about the symptoms. So since this tissue is similar to the endometrial tissue, that means it's sensitive to the hormones, just like the way our endometrium is sensitive to our menstrual cycle hormones, the progesterone and the estrogen, which are basically our main basic hormones, regulatory hormones for menstrual cycle. So you find these tissues are also hormone sensitive. And during the menstrual cycle, whatever is happening in the uterus itself is also happening in these tissues. But now when it comes to during the menstruation itself, the shedding of the endometrium, since this tissue now is implanted else and there's no shedding, one, we can find these women now coming in with concerns of severe pain. Mostly it's severe cramping pain if it's within the pelvic region. If it's outside the pelvic region, maybe in the abdomen or in the lungs or in the brain, you can have now severe pain. Someone may come in with severe cramping pain in the abdomen, maybe chest pain, coughs in the chest, and also for the headache, they can always present with very severe headaches, which we call the migraine headaches. Secondly, we can have very heavy bleeding. Heavy bleeding is a second issue. The third concern is mostly found within the vaginal canal. You'll hear women complain about pain during sex. So anytime they're having sex with their spouses and it's within this cycle line, they'll also complain of very severe pain. And the unfortunate bit, which causes most people to seek care of, that's why we speak about it so that people can seek care early, is infertility. So you find people have been suffering, they've been having this painful menstruation, heavy bleeding, they're having issues with their husbands, but maybe years down the line in marriage and they get getting kids, that's when they end up coming to hospital reporting of infertility. But you find this is an issue that has been ongoing for years. So infertility, I feel at this point now, is always, most of the time, it culminates to that if not treated early.
And does endometriosis have any specific origin or causes?
So there's a lot of debate about that, though currently there is no known cause that you can easily pinpoint. But there have been different theories that have been associated with that. So one, there's the familial history. If there's a first degree relative in your family who suffers from endometriosis, this gives you, as a family member, as a close family member, close to a 50% chance of getting the endometriosis. So it increases your risk factors by close to 50%. The second thing that is thought about is metaplasia, which is the change of cells. So you find like in the peritoneum, we can have the peritoneal cells changing to exhibit symptoms like those of the endometrium. So that is the second thing that is thought about mostly. But so far we don't have anything else exact. But the other thoughts, which are quite extensive, such as immune factors being involved, though all these things are still under study, but for now that is what we know.
And are there conditions that are similar to endometriosis?
Yeah.
Which kind?
So we have some bit of conditions. So on the endometriosis, yeah, we've talked about some of the risk factors, of which one of the commonest also that we forgot to mention is whereby we have in retrograde menstruation. This is where we have in the menstrual blood, the menstrual flow backwards. Yeah, so at some point now, that's how we'll end up getting the endometrial tissue getting implanted maybe to the fallopian tubes and in the ovaries. So some of the conditions that are similar to endometriosis, which will most probably present with one or two of the symptoms about the pain for menses. One, we have one of the commonest is the pelvic inflammatory disease, of which this is an infection of the female genital organs, mostly the uterus, the fallopian tubes, the ovaries. Yeah, which is mostly a sexually transmitted infection that will present close to the same. Second one, we have adenomyosis, which is also becoming a common disease now that people are seeking better healthcare services. This is where now we find the endometrial tissue, the tissue lining the uterus now, buried in the muscular wall of the uterus. This will also cause a lot of pain. Another thing is a common thing we have is fibroids, whereby we have got these growths in the uterus, and also they'll also present with pain and also heavy bleeding. Yeah, so these are some of the common conditions that can easily be confused for endometriosis.
And since there are several conditions that can easily be confused for endometriosis, how does the clinical team try to diagnose and rule out that this is what you're dealing with?
Okay, that is something tricky, because you said if you're having any symptoms, you seek care. But when you come to us seeking care, one will start with taking a detailed history from you. That is where we will ask about the onset. We will ask about if you're coming because of pain, we want to know how is the pain, for how long has this been going, and there's associated symptoms such as the heavy bleeding we're talking about. Do you have a family member who is also suffering from the same? Because you see, you can be two people suffering but have never gotten a diagnosis. Yeah, do we have someone known to suffer from the same? So that will be our first point. The second point will be a thorough exam. So we'll have to examine you fully to be able to understand how these symptoms are affecting you. The third one, we can do some images. We can start with simple imaging such as pelvic ultrasound, because this will enable us to rule out other things. Because if it's a fibroid, this will easily be picked up on an ultrasound. If it's something like pelvic inflammatory disease, it will be tied down through our history, our pelvic exam, and we can have some suggestive features on the ultrasound and also some lab investigations. But the main diagnostic feature for endometriosis is diagnostic laparoscopy, which is more of a keyhole surgery, whereby we have to go to theater and then assess your pelvic region, surgically, and also take samples where necessary.
So this means that if a client is really suffering pain, they have to invest in trying to find out their issue, because some might just want the painkillers and go home. They just want the pain to go away without knowing the issue is. So I think with this knowledge, people will seek help more.
Yeah, I feel it's important because we always say health is wealth. At the end of the day, we love to spend some money for us to be able to get this, but thankfully, in most of our facilities, some of these tests can be run, and we are able to get diagnosis. Because the more we delay, we'll end up with more suffering. Because you see, even persistent intake of these painkillers, of which mostly they will also result to damaging our gut, of which now this will be a secondary issue that we bring. And then we've also talked about something like infertility, which we're saying is also one of the major issues associated with endometriosis. So if you started symptoms early, you never sought care, it's years down the line that's when you're coming to seek care. I think at some point maybe we may have delayed our window of care and complicating things further.
So that means, according to how somebody perceives illness, it can take them even more than 2 years, 5 years, 7 years to find out the issue with them.
Yeah, I understand the health-seeking behavior of our people is actually difficult.
Yes.
And most people don't want to waste time in hospitals because you'll come, maybe you'll see me as a clinic officer and then I'll be like, we'll do the preliminary test, but I'll have to refer you to a gynecologist. Someone may be like, that is quite expensive. Maybe we're in a facility where we don't have an in-house gynecologist and we have to send you out. So I feel at some point people don't want really to invest on healthcare, and also where people want to invest in healthcare, sometimes finances can be a challenge, and even getting the diagnosis itself at times can prove to be a challenge. So I understand, especially with endometriosis, it's a really tasking disease, but you all have to come together to champion for these people. I feel at this point you have to champion for them for more affordable treatment. Yeah. And also more accessible. It has to be accessible and affordable for them to be able, because someone may be so willing to get these services, but one, they don't know where to get them. Two, they don't have the knowledge, because most people don't know much about this. People, anytime you talk about pain, you're being told that is how you're becoming a woman. Wait until maybe you get a child, the pain will go away. Then you train for a child, 4 or 5 years, you never have a child. Yet you don't know whatever is causing you not to have this child, whatever is causing you the pain, is the actual disease that you should be seeking care of. So I believe it's time we embrace reproductive health issues and stopped shaming people when they come out to talk about it, or when they come to seek care, and we support them more and champion for better health services for them.
With what you have said, that means that there are some myths or misconceptions that people have embraced surrounding reproductive health. Are there others that you have interacted with, maybe some misunderstandings surrounding reproductive health?
Yeah, people have got different ways of dealing things. Yeah, because you find when you talk about reproductive health, this is something that out there in the community, people want to talk in hushed tones. You don't have to be loud about it, because if it's concerning women, then. But I think in the recent past, we've even seen some of our MPs go to parliament with trousers stained, advocating for free sanitary towels. We've seen people talk about family planning, of which that is another area that people have got lots of issues about it. And I feel it's also a place that at some point you also need to talk about it. Yeah, and also concerning menstrual hygiene.
Yeah, and concerning endometriosis, are there some treatment options that people can opt to, and how effective have they proven up to this point?
So as I said, endometriosis is, I can say, a task for them, because this will require specialized care. As I said, if you came to me, I'll definitely refer you to a gynecologist who will mostly see you, manage you, or refer you to an endometriosis specialist. So for this, it's something that involves symptom control first, because we have to make you comfortable as a patient. So you have to control your symptoms, and two, now you have to deal with the disease itself. Yeah, for the symptom control, because most of the time the main thing is the heavy menses and the pain. So for the pain, we mostly use our non-steroidal pain meds, something such as brufen, meloxicam, or other stronger pain medications to manage the pain. Then we saw that this is mostly hormone dependent, because it's mostly flowing within the menstrual cycle, which is mostly hormone driven. So at this point, also to control, to regulate your hormones, or to regulate your cycle, because you find some of these people have got irregular cycles. You'll find people are being put on contraceptives, combined oral contraceptives, so as to regulate their periods, or maybe to balance their hormones. But finally, you will have surgery. You will have to undergo surgery for this. Yeah, mostly to remove, because we're saying talking about ectopic tissue being found in other areas, and you'll have to get these tissues removed.
Is it possible for the tissues to grow again after they have been removed?
Yeah, we saw from some of the positive factors, we saw something like retrograde menstruation. If that is what caused maybe the initial cause, yes, we've removed the ectopic tissue, but if this happens again, then most probably there may be a chance of recurrence.
The pain, since we see most girls experiencing pain during their periods, does that mean that they could also have this endometriosis?
No, I can't really say that every painful menstruation equals to endometriosis. Yeah, there's some among all those who are having the painful menstruation, maybe with proper checkup, they'll end up maybe having that diagnosis. But it's not every painful menses is always endometriosis. One, there's some who just have normally painful menses. Other women, we find some women struggle with things such as fibroids. They'll also get painful menses. We've also talked of associated issues such as maybe they may be having some cysts, maybe ovarian cysts. They may also present with these pain. Yeah.
And what extent of pain can a woman feel and start getting worried about other conditions?
So the extent of pain, I believe most women generally don't have to feel pain during their menstrual cycle, because this is a physiological thing that is ongoing. Or if at all anything has to happen, it's just a mild discomfort. But if at times you find this left debilitating pain whereby you can't carry out your usual work, you can't go to work, you can't go to school because of pain, you can't run, you can't do your usual work, then I think it's time you really need to seek medical attention.
And are there other causes this painful periods? If maybe somebody is not sick, can maybe something like stress make somebody feel more pain at times, or what happens?
So yes, we have the psychological behind menstruation, but you find most of these things will most probably predispose you to irregular menses as opposed to pain, because you see pain is associated with release of some bits of hormones. So mostly you will get, if there are other issues associated, you most probably end up with irregular menses as opposed to painful menstruation.
How can somebody know which type of cycle they have in their menstruation?
So generally, women, I think we have mostly 2 to 3 cycles. Either you have to be in a 21-day cycle, 28-day cycle, and some go to 32 or 35-day cycle, which is regular. But you find mostly there are some who also experience an irregular cycle. One, you find mostly after attaining menarche, this is the age when you get your initial menses, before the hormonal regulations, young girls may get the irregular menses. Two, we have people who are using family planning, whether it's the usual family planning or the emergency pills. These can also destabilize their hormones, irregular menses. Three, we have or other pelvic issues, such as when someone has got a disease like pelvic inflammatory disease, or they are having these fibroids. These can also make them get irregular menses. There are also those who have the thyroid disorders. Yeah, this can also predispose them to irregular menses, and definitely pregnancy will hold your menses. Yeah.
That is true. Yeah. So, at what age or maybe at what point can a lady get worried if maybe they have not started their menses, or if they are missing? They have started, but now they are missing them.
So you find from the age of 15, 16, these are teenagers. By then, your body should be ready enough to start menstruating. And this goes all the way up to the age of 45, and some extend of the to age of 50, where now they attain the age of menopause.
So maybe at 15, if I don't see my menses, I can start getting it.
Yeah, at 15, around 15, 16, then maybe after that you still no sense of any. Then I think because you find some people may be getting menses, but they are getting menses, but there is some bit of an anatomical issue, so it's not able to flow. So I think at the age of 15, 16, if still no menses, then you can try and seek some bit of medical care and see. And if everything is ruled out, then you can still continue it.
And for such people, maybe if they have not seen their menses, is it possible for them to get pregnant?
It's very possible.
How?
Yeah, it's very possible because they say pregnancy isn't determined by the menses themselves, but it's determined by the ovulation. So, assuming you're involved in sexual intercourse within the period you should be getting your first ovulation, so that means you end up getting expectant before you ever experienced your first pregnancy. Yeah, so it's possible for one to get expectant before getting their first menstrual cycle, especially if they are involved in intercourse within that period, of which you see it's not 100% guaranteed that if you had your intercourse within that period you will end up pregnant, but there is a chance of you getting expectant before your first cycle. Yeah.
That's interesting.
Yeah.
And let's talk a little bit about menopause.
Yeah.
And maybe is there a specific age it begins, and are there some signs that somebody is getting into menopause?
Yeah, we always, you see when people talk out there, they're saying like by the age of 45 you should have attained your menopause, but I think we can say menopause is personally dependent. There are some who will go into early menopause as early as 40, 42. There's some who will get there usually to the usual age of 45, 46, 47, and there also people will get delayed menopause. These are people who receive their menses all the way to the age of around 50, 51. So I can't really say there is a one specific number which acts as a magic number for menopause, but I can say it's individualized. Yeah, some of these symptoms, I think most of the people, most of the patients have met. I think hot flashes is one key feature that has featured in most of them. This is where you find someone is just seated there, okay, but then all of a sudden they have got this wave of heat that hits them, started getting sweaty. Yeah, that is one thing. And the second one, I've seen people talk about thinning of their hair. Others say they are getting some bit of tremor. So it's quite diverse according to different people. And then people will just get menopause and they just reminisce, oh, it's been 1 year without receiving my menses, which now marks them getting into menopause. Yeah, so I think even that it's quite individualized. You can't pinpoint all points to one person.
That's interesting. Can these people can they also get hormonal imbalance? And is it okay? I really don't know how to put that, because I think that is the point where the hormones are diminishing. they get imbalance?
So you find those getting to menopause, yeah, you see at this point, because you're talking all this is key player is hormones, but by the time now they're getting to menopause, you find we don't have a very key role of hormones at this point. But now we have got other things that can become post menopause. We can have women presenting with abnormal uterine bleeding. This is where someone tells you I've been period free for the last 2-3 years, but all of a sudden now I'm starting to get my periods again. Or maybe anytime I'm having sexual intercourse, I'm having some bit of bleeding. So you find these are the other things that now come after. Some that are likely to appear after menopause, of which now these are also red flags when it comes to postmenopausal women, because that means there is something unusual ongoing within the reproductive system that is not okay. And you find in our society the commonest thing is something like cancer of the cervix. So anytime they get these abnormal bleeds or a change after menopause, they now start getting these changes. Then it's also good for them to seek urgent medical attention.
Cancer of the cervix. That's interesting.
Yeah, which is one of the main causes of death among cancer patients. Yeah.
How can it be diagnosed?
Cancer of the cervix, one we talked about, especially if we are dealing with the postmenopausal, the common feature mostly they come with maybe full smelling vaginal discharges, they will come with pain and some bit of bleeding during intercourse, or they may also start getting this cyclic bleeding or just heavy vaginal bleeding. These are some of the key indicators that will tell you most probably there's something ongoing. The others who just get these subtle symptoms but don't talk about it, but they also have associated low abdominal pains. They may start getting other symptoms such as weight loss, and they come in. So when they come in, it's up to you as a clinician to piece all this information together and then send them in for investigations. Commonest investigations that we do is a pap smear, ile ambayo watu wengi wanaenda wanafanyia but hawapendi sana since it's a bit uncomfortable, but that is one of our main diagnostic features. And after the pap smear, then if there's anything suggested, then there are other tests that follow through until now we are able to link a patient to care.
Wow, thank you for sharing all this information with us. We really appreciate it. I think we can talk about family planning, and are there some methods that somebody can use for family planning?
Yeah, family planning. I think this is also another controversial topic mostly in the society, since people believe that it's the woman's role, to have the family planning methods. But we find that family planning by itself, it gives us a chance to plan on when we want to get children and the number of children we want to get, because it assists us to prevent these unintended pregnancies. And so on the question on whether there are methods, if there are a couple of methods, we find we have different classes of methods. We have the natural method. There's some people who stick to it, and they mostly use the calendar method, whereby they are able, but for this is for people with regular cycles. So for them, they are able to highlight which are the safe days, when are they ovulating, they know those are the red days, they don't have to engage in sex, and then the days post-ovulation. Though I can't guarantee it's 100% method because it's user dependent. The second one, there's some people who trust maybe on the withdrawal method, though it's not also 100%. But then we've got other methods. We have other methods such as the barrier methods. We've seen people embrace the use of condoms, whereby we have both the male and the female condoms. So these act as barrier methods. Then the widely used method is the the use of hormone, maybe pills or injections. This is where now we are having our hormonotherapy which is most probably maybe our oral contraceptives, our injectables, such as the commonest, the 3-month injections, the depo. We have the implants, the implant and the gel, whereby we get maybe for a period of 3 years, or you can choose for a period of 5 years. We have the IUDs, the ones we insert to the cervix. Yeah, those are the main hormone-based methods, yeah, that are currently being used. And we don't have to forget about the permanent methods. The tubal ligation for the females, whereby we have to tie your tubes, and also vasectomy for men. Yeah, though still not so many people willing to take them out. Yeah.
And how can somebody choose the best family planning method since there are so diverse?
Yeah, so you see, there's no one which is totally tailor-made for a specific person. There are different factors that you put in place when choosing your family planning method. One, the first thing, you look at your age. At what age are you? What do you want to achieve? When do you want your next child? How do you want to space your children? Because if you just got a child and the next time you want to get another child, it's 5 years from today. You're not a person that will advise you to be on daily pills, because you see, taking daily pills for the next 5 years may tend to be quite cumbersome. At a point, you may even forget them. Same way, I wouldn't advise you to get a 3-month injection if there is no any other contraindication. So you find this is totally dependent on your age to how do you want to space your children, because the longer the duration, you use a longer duration method. The shorter, if you just want to get your child in the next 1 year, maybe then you can say you can use a 3-month injection, since those are just 3-4 injections, and you're done and you're now ready to get expectant again. 3, your health determines a lot, because we find that the people with different conditions that are not compatible with different methods. So anytime you're going to seek services for the best family planning method, it's okay to highlight your issues. Do you have any underlying medical issues? Do you have issues such as high blood pressure? Are you on antihypertensives? Are you having conditions such as maybe some bit of heart issues? Because all these things, different medications have got different side effects, and they have their contraindications. So by if you're having this issue, you cannot, it's not advisable to use this method, since the risk will definitely outweigh the benefit of you just preventing the pregnancy. Yeah. The next thing is about desire for future pregnancies. The first one, you talked about how you want to space your children, but maybe you're a mother of 4 today at the age of 35, and maybe you don't desire to get another child. Yeah, at this point you can say, do I want maybe to do bilateral tubal ligation and say that's it now, let me get involved in a permanent method? Or are you still, yeah, maybe I can do a long term and then consider. The next is the side effects, because some people maybe you just okay doing any, but maybe use a specific method, gives you, maybe you do the 3-month injection and you end up maybe very heavy bleeding. You see, that is not then you could consider doing again. So even the side effects you get from some of these family planning methods can also determine your next method that you can use, because at this point you can say, no, at this point I'm not doing any hormonal based method, then let me go for copper IUD. Yeah, and also finally, you see, as partners, because we say family planning is not just the women's job, it's a couple's thing. If you're a couple, you have to decide, what do we want? Are we going on mono? Are we going on mono? Are we just doing temporary? Are we doing a permanent method? Yeah, so even that plays a role, and also convenience. Because you see, you may be in a place whereby I want you to get 3-month injections, but you're like, no, that will not be applicable for me at this point. Or I want to give you the 5-year, but you're like, no, I can't do that. So even personal preference and convenience also plays a key role. So you have to go through all this with your healthcare provider for you to get which is best suited for you.
And what about the recent mothers? Maybe somebody who has just had their child, maybe in a span of days or weeks. Which methods are available for them?
So for lactating moms, we have one of the natural methods that I forgot to mention earlier, which is the lactating amenorrhea method, whereby you find, if this is for mothers who are exclusively breastfeeding. Hawa si wale wanaenda nyumbani alafu wanaanza kumix, mtoto ananyonya alafu bado anampea chakula, hapana. These are for those who are exclusively breastfeeding for the 6 months as advised. So for these, you find if they're exclusively breastfeeding, some of them end up in a period of amenorrhea, so they are not menstruating at this period. So so this blocks their ovulation. So this can be a safe thing for them, though it's not something that I could highly, especially in the recent days whereby not many people are adherent to the 6 month period of exclusive breastfeeding, and you see also our bodies are made different. And maybe I may adhere to that, but you find me in myself on that month I'm already busy ovulating and menstruating, and someone else will go even for an entire year. Two, it's about because the next thing they can do an hormonal, which mainly at this point, if maybe they want to space their children for long, they can go for copper IUD, which is an hormonal. The other option then, now that they have, because at this point you can't talk about abstinence, because I believe these are married women, so, and you're not going to get into their partner's conjugal rights. So you can also have based on hormonal, whereby we can do the implants, which are, at this point we're just doing progesterone only, up to the age of 6 months, lactating to the age of 6 months. So for them, we can do implants, maybe for the 2 or for the 3 or 5 years, or they can be encouraged to do the progesterone only pills.
And maybe are there some misconceptions that you have interacted with surrounding family planning?
Yeah, you find different people believe different things. There are most people are open to these and they feel that it's a good thing, since now they are helping prevent a lot. One, we have been preventing unintended childbirth. Two, it helps it improves on the maternal child health, since one another is able to space their children apart. They're able to breastfeed these children well. They are able to provide for these kids, so we'll have a healthy child. And also the complications that comes with pregnancy and childbirth also go low when a mom is well prepared and a mom has got the choice to choose when and how many to get. But now there's some people who are against this use of family planning. You find some people believe that once you use a family planning method, you end up infertile, because you find that as once they start using the family planning, they end up in a period of amenorrhea for the better part of the time they're using the family planning method. And so something now, because maybe you used a Depo-Provera and you haven't been getting your menses for the maybe 1 year duration or 2 year duration, maybe then this will render you infertile, of which this is just a myth. But you find that once you discontinue use, over time your body is able to regulate itself and you're able to go back to your normal menstrual cycle. Yeah, so second misconception I've heard people say is that family planning causes cancer. Yeah, we know different family plannings have got their different side effects, but we can't directly say that family planning causes cancer, of which you see from different studies, from the use, we are getting better advantages in terms of maternal child health with use of family planning. And then some others say once you get like the implants, once you get the implants, some say, oh no, you see, when you get that implant just below your skin, it will travel. I've even had some say, oh, it will find a way to get into the veins and then travel to your heart and then cause your death. Others say once you get an IUD, of which we always talk about go to a health certified person, to a person is certified to carry out these procedures, so that even if you're getting a IUD placed, let it be placed in the right position. Yeah, so because you find some people say, oh, once you get the IUD, once you, whenever you have sexual intercourse, your husband will always feel it, of which I find that is a myth. To those of you, that is totally a myth. So because some say, oh, once you having intercourse, your husband will be getting pricked, of which you find that the IUD is way up in the cervix, and the men are just in the vaginal canal. So that is a myth. Others say, it will just get displaced and disappear in the body, and that's how now you'll never get expectant. But I believe if it's placed correctly and you can be able to monitor and track it, then it will be safe for removal by the time you want it done.
I think this knowledge should help people overcome the fears that they have been having. And we can talk about the emergency pill. Is it a family planning method, or what is it?
Okay, so the A pill, which is most people call the morning after pill. So for that, it's not a family planning method. It's an emergency pill. Just as you called it, it's an emergency pill. So it's not an everyday use, it's not an every week use, it's not an every month use. This is a pill that you use when during unforeseen circumstances. Maybe someone is sexually assaulted. You can't tell them, no, you have to use family planning, because you see, for our usual family planning methods, they take some duration before they take effect in the body. But now, in these emergency cases, whereby maybe we're having someone who has been sexually assaulted, or we're having someone who was using a different method, maybe someone was on a barrier method, maybe something like a condom, and then they got a condom burst. What do? They really wanted to prevent this pregnancy, and they'd already put in measures to do that. They already had secured a condom, but now we in this situation. So those are people that should be using the emergency pills. But for any pre-planned meetups, pre-planned intercourse, then that is a misuse of the drug. Yeah.
So what are some risks that surround frequent use of the e-pill?
So you find the e-pill is quite high on hormones. So I've seen some studies done show that yes, one, it will definitely, because it's quite high in hormones, one, it will alter your menstrual cycle. And you see now, if maybe you had such a good regular cycle, you start now using your e-pills on a regular basis. That means now it will be hard for you to track your cycle and know, when am I sick, when am I not, when should I be menstruating, when should I not. Yeah, so I think the biggest risk with that one is the irregular menses. Two is hormonal imbalance, because you see it's something that is quite high in hormones, so it may also lead to hormonal imbalances not coming with sequential effects, of which we are talking something like heavy menses as a result of all these. Yeah, and then there's also a talk about reduced effectiveness over time, because you say if you're using it and you know very well you're meeting up with someone and you'll definitely get engaged in intercourse, and your e-pill is what you carrying as your go-to protective measure, then over time sometimes it can be rendered ineffective. And then we know that e-pills don't protect us against STIs, because I believe if you're in a mutual relationship with a person, then for this it's not just a one-time thing, it's something that will require repeated uses, and for that you may consider a long-term method. But now you find most of the people using the e-pills, mostly they have got different sexual partners, and you see for this now we're not going to protect against STIs, which is also a downside of that.
And can you tell us how somebody can take care of themselves better, reproductive wise? Maybe is there a way somebody can prevent themselves from experiencing some illnesses?
Yeah, reproductive health one. I feel if it's starting with what you said last, protecting ourselves against some illnesses, I think one of the commonest associated diseases is the sexually transmitted infections. If you're not married, then abstinence is the key. Yeah, because if you're abstaining, then where you getting the sexually transmitted infections from? Because you see, you may have one partner whom you're faithful to, but they're not faithful to you. They also have multiple sexual partners, and they may make you go down with these illnesses. So I feel for the unmarried people, abstinence is the key. Two, we've talked about menstruation, good menstrual hygiene, the quality of pads that you are using, how frequent we change them, because you see, how well do we take care of ourselves during this period? Because this is a time we're talking about how regular are you taking your baths? Will you be menstruating for 3 days and you're just showering maybe once in every 2 days? Yeah, so self-grooming and hygiene is key at this point. And then we also have regular checkups. We always advocate say anyone above at the age of 25, you should at least have a regular gyn checkups whereby you're also getting screened for some of the things we've talked about, something like cervical cancer, which is taking a toll on our healthcare since we see a very high number of cases of cervical cancer and it being one of the leading causes of death. Yeah, so I feel that is also something that we can advocate for, a regular screening, simple pap smear. Then after that, depending on the results, to advise how often, because we find this is not something you're going to do on a yearly basis. Yeah, so good proper health checkup. And then we have currently we have the HPV vaccine rolled out, which is we hope it's going to be a game changer when it comes to cervical cancer. And we're seeing it getting administered to our young girls who are not yet sexually active. So also encouraging people to uptake such initiatives whereby when we have these vaccines getting rolled out and we're being told about the advantages, we can see that yes, most of our women are going down with cervical cancer, but if we give our girls these vaccines, since we see most of the cervical cancer is mainly caused by the human papilloma virus, which is mostly sexually transmitted. And if our girls are able to uptake this vaccine, then this will lead to a decline in the cervical cancer diagnosis in the future. So I feel this is something that I can also encourage people to do. Then there is also avoiding of self-medication. When we were talking about endometriosis, we talked about whereby people just feel they're having pain for menses and they don't seek help services. They just go in a chemist or somewhere, just get over-the-counter pain medication just to control their pain. But in actual sense, it's not just normal pain. There's something else that is ongoing. So also avoiding self-medication. You'll find some people getting STIs. Different STIs have got different managements. But you'll find maybe someone is self-medicating on a totally wrong drugs, and you find some STIs can lead even to issues such as infertility. And if now you are having this issue and you're self-medicating on the wrong drug, you see, you end up with a sequelae of these infections. Yeah, and then also we can, because you see, anytime we're talking about these campaigns, talking about the different things, like how now everyone currently, most people are talking about endometriosis and adenomyosis. Some time back, everyone was talking about fibroids. I think it's also good to get involved in these campaigns, either as survivors or healthcare professionals, or even as just the general population. Because once we amplify our voices, then we will be able to advocate for these people to get better services. Yeah, and finally practicing safe sex. We said abstinence, and then if you're married, then let's stick to one partner. I think that's it.
Wow. It looks like knowledge is available, but people don't know where to find it. So I am happy that we have interacted with you. It has been so enlightening, and I hope that our viewers who have been following us, they won't keep this knowledge to themselves, that they're going to share it out there so that many people can get the help they need. So maybe is there a closing remark you would like to give to the viewers so that we can call it an
Okay, thank you, Kaira, for hosting me today. I think it was quite an interesting topic for us to discuss about, and things concerning reproductive health for both men and women. It's something that we can discuss for days and weeks, but the bottom line is knowing to seek medical attention, know where to seek it, and when to seek second opinion. Because you find, I talked about, if you come to me as a general practitioner, there's the much that I can do, and after that, I can refer you to a specialist who can also maybe refer you to someone else. So we don't have to take offense when you go to a facility, because I've seen people go to a facility and they're told, yes, we'll do 1, 2, 3, but you'll have to seek attention from someone else. And they're like, no, if you don't know them. So we have to understand the different levels of healthcare that we have, and when and where to seek. If there's something you notice something abnormal, it's time you speak out about it. If you're being followed up somewhere and you don't notice much change, and maybe you feel as if your needs are not getting addressed, it's always good. Also, you can also choose to seek a second opinion. But at times also there are moments where we need some little bit of patience. But there are other times you have to know when do we seek second opinion, or when do we now move to the next level of care. But the bottom line is we practice safe sex, have good health seeking behaviors. Let's not shy away from talking about our issues, visiting facilities, undergoing tests and as advised by our professionals, and also the family planning uptake. I think it's something I would encourage couples to do it as couples. Let it not be a woman initiative, but let also our male counterparts be involved in it. And after that, I think it will really enable us to create a very healthy environment for our ladies and men seeking reproductive health services in our different facilities. And maybe over time, men will be encompassed in these journeys, maybe the endometriosis journey for their wives, the infertility journey. I feel it's something that men should also be heavily involved. Yeah.
Wow, thank you. God
Thank
bless you even for sharing the knowledge with us. So that is it for the episode. Like, share, subscribe, drop your comments. If there is something you still have a question about, you can drop it and we'll make sure that it has been addressed. Bye.